Today we're talking about Selinexor or Xpovio, and I asked Dr. Cole to speak on Selinexor, Carfilzomib, and Dexamethasone in treating patients with relapsed or refractory multiple myeloma. So we're going to be hearing about Selinexor in general, and then also the results of the phase 1 study. How did this trial affect options for relapsed refractory patients? What role does Selinexor play in relapsed myeloma? Our speaker, as I've mentioned several times, is Dr. Cole. He's a board-certified hematologist who completed his undergraduate degree at Michigan State University and his doctoral degree at the Ohio State University College of Medicine. He began his postdoctoral training in internal medicine and hematology oncology at the University of Michigan Health System. He has had the opportunity to do post-fellowship laboratory research in the Jerome Lipper Multiple Myeloma Center of Medicine at Dana-Farber Cancer Institute, Harvard Medical School in Boston, Massachusetts. And this opportunity then led to a staff lectureship at the University of Michigan, concentrating primarily on clinical research in multiple myeloma. He then moved as an attending physician to Wisconsin for 9 years, and while in Wisconsin, he expanded his research interest to include multiple myeloma, non-Hodgkin's lymphoma, and a lot of other things. He has published and presented his research at the American Society of Hematology and the American Society for Apheresis national meetings. He is also has a commitment to patient empowerment and education, working with several local and national patient advocate associations. So Dr. Cole, the time is now yours, and we look forward to your presentation. Thank you for joining us today.
Well, thanks, Audrey. And thanks for inviting me. And let me get my screen. And there we are. And so do you see my?
Yes, it looks perfect.
So, thanks for inviting me to talk about our project that we worked on several years ago with Selinexor, Carfilzomib, and Dexamethasone. And one thing about my disclosures is that the company that makes Selinexor, Karyopharm, I don't have any conflicts of interest with them specifically. And I did use some material that's on Clinical Care Options website that has a lot of good information, by the way. So what we're going to talk about today is a little bit of level setting about how clinical trials are designed, what response rates are in clinical trials, and how to read some of the graphs that I'm going to put up. This will be followed by what is relapsed refractory myeloma. And then we'll talk about how some of these drugs work, Carfilzomib and Selinexor specifically. And then we'll talk about the Selinexor clinical trials that have led to FDA approvals, including Selinexor, Carfilzomib, Dex, and 2 different trials that I'll talk about. And then why, just like Audrey had mentioned, what we're going to talk about a bit is why this study matters in 2022. So a little bit of background about clinical trials is that when we talk about clinical trials and results of clinical trials, what are we looking for? Well, we're looking for what response criteria. How well do people respond to these different medications? And so you'll see the letters CR and VGPR used a lot. In CR and VGPR are the depths of response, that a complete response means that the myeloma protein is completely gone away. And in terms of complete response means that the free light chain and the bone marrow biopsy is completely normal without signs of myeloma. A very good partial response means that you've gotten rid of 90% of the M protein. And a partial response means you've gotten rid of more than 50%. One thing that isn't part of the official response criteria, but that you'll see mentioned with Selinexor a lot, is minimal response. And that's when you've had a response where the myeloma protein, either the free light chain or the M protein, has gone down by 25 to 50%. And so we call that minimal or minor response. And stable disease means that although the disease was progressing, that the M protein didn't change after you started therapy. So there was no change, which in many cases can be a good thing, which means that the cancer is not at least getting worse. The other thing that we talk about is how well did it work or were the side effects. So you'll see OS means overall survival. So not just how long do people live in the terms of the study, but how long do they live in general after the treatment. Progression-free survival, you're going to use that term a whole lot. PFS means how long did this particular intervention work. And adverse events, AEs, are the side effects of the particular regimen. And then, I don't know, you probably have seen a lot of Kaplan-Meier survival curves because they're used a ton in myeloma research. And a patient asked me, how do you read these things? And basically, it is a way to compare two groups to each other. It's a quick eyeball way to say, did one intervention work better than the other? And in this example, the blue curve is group 1, the green curve is group 2. And if you look at like 20 months, you'll see that 60% of the blue group did survive, while 15% of the green group survived, which means that the higher that survival curve, group A or group 1 is doing better than group 2 based on where they are on that curve. And so we'll be using quite a few, and I'll have my smiley faces and frowny faces are ready to go to help you interpret those results. So the first question that people ask is, what's relapsed myeloma? And that's when the myeloma is returned after a particular treatment. And people will use the words relapse or recurrent or progressive pretty interchangeably. But since myeloma doesn't have a cure yet, at some point patients will have a relapse. And when they have that relapse, they are then given therapy for relapsed myeloma. And if they achieve a second response, then they have a second, third, or fourth response. However, if the disease doesn't respond to a particular therapy, so they're relapsed and they get treated and it doesn't work, then we call that refractory. And you'll see RRMM, meaning relapse refractory myeloma. And that's where a lot of the new therapies are for those patients that have relapse and refractory disease. A kind of a graph of that would be that when patients are diagnosed, you'll see that on the one axis you have the M protein of when they first were diagnosed with myeloma, and usually that M protein is pretty high. They get some type of induction therapy, RVD or Relapsed Velcade dexamethasone is a common induction therapy. And then patients will get a transplant that will drive their disease down significantly. And then they go on a maintenance therapy. Hopefully that's for a very long time to keep the myeloma under control. So we call that plateau phase or remission. And that's a first line of therapy. So you'll see lines of therapy used quite a bit in this talk and with myeloma in general. When the M protein begins to increase again, and when patients begin to relapse, we'll call that a biochemical progression. If the M protein continues to go up, and if the light chains are greater than 10 milligrams, or the M protein is going up by 0.5, we call that a biochemical remission. And as long as there are no signs of lytic bone lesions, anemia, or hypercalcemia, you can continue to watch it, but at some point, you want to make sure you intervene before they develop those Crab symptoms. And that's when you start the second treatment. And then the M protein goes down again. Then you continue that second treatment for a nice long time, but eventually, and that will be the second line of therapy. And then that pattern of relapse, response, and then plateau plays out over and over again. And those are the third, fourth, fifth lines of therapy that a patient will use. And so we call those relapses, third, fourth, and fifth relapses. But eventually, at some point, the myeloma, you do intervene with a treatment, and then it doesn't respond, and that's refractory disease. And that's where the science and the clinical trials comes in to knock down that disease. And there's been a lot of science and clinical trials over the past few years, since 2015, we've had 31 different drugs regimens approved with 14 different agents. And you'll see on there in the middle, Selinexor, dexamethasone, and Selinexor, Velcade, and dexamethasone, kind of in the middle, being recent additions to the arsenal in the past couple of years. So again, we've had 14 currently approved. 2 drugs were removed because we weren't using them that much, to be honest with you. So we have lots of tools to pick from. And the question is how do some of these drugs work? And so I'll start out with talking about a little bit of science about how myeloma works. So here's a myeloma cell on the screen, and it has its interleukin-6 receptor. And myeloma really likes interleukin-6. It's dependent upon it. And the reason that myeloma cells are dependent upon IL-6 is when IL-6 engages its receptor, it activates one pathway called the JAK-STAT pathway that goes to the nucleus of the myeloma cell and activates proteins like BCL, XL, and MCL1, which have the myeloma cells not die. Anti-apoptosis means cell death. Anti-apoptosis means the cells don't die and they survive. So that's a bad thing to have a cell that won't die off. The second thing IL-6 will activate is a RAF-MET kinase pathway, which turns on cycle progression. So the cells aren't dying and they're making more of each other, which is bad. And then after engaging its receptor, it'll turn on the PI3 kinase pathway, which turns on nuclear factor kappa B or NF-kappa B. And you see all these things are going in and out of the nucleus. So we'll talk about how that's important to selinexor in a second. And activation of NF-kappa B makes more of those cytokines like IL-6, which makes the myeloma cell impermeable to chemotherapy and resistant to steroids, which is why chemotherapy and steroids have not worked well alone for myeloma, because interleukin-6 makes the cells reproduce quickly, makes them not die, and it continues to use those supportive cytokines. If those cytokines are so important, where do they get them from? Well, they get them from the bone marrow stromal cell compartment or the osteoclasts in the long bones. And when myeloma cells attach using various adhesion proteins such as ICAM1 and VLA4, it will activate those bone marrow stromal cells. And the myeloma cell will give you a little bit of vascular endothelial growth factor, which again turns on that nuclear factor kappa B, which releases IL-6. And I told you that IL-6 will activate a number of pathways in those myeloma cells, including activating more NF-kappa B, which will produce more IL-6, which will attract more myeloma cells to the microenvironment. They'll produce vascular endothelial growth factor, which will grow blood vessels in the area to supply these new myeloma cells with food and nutrients, and other supportive cytokines, including more VEGF, which turns on more NF-kappa B, and the circuit continues there, which has the myeloma cells, again, impermeable to chemotherapy, impermeable to steroids alone, and had the myeloma cells living pretty large inside the bone marrow until we found out a way to inhibit that pathway. So how did we inhibit those pathways of IL-6 and the bone marrow adhesion to the bone marrow stromal cells? We use science. We use science to figure it out because chemotherapy wasn't going to do it for us. So one way that we did that was the inhibition of the proteasome. So how does that work? Well, I talked about how NF-kappa B is in the cells, and after the cytokine, which is the IL-6, engages, it then activates this protein called I-kappa B. So you see up here that NF-kappa B is nicely tucked into the crib of I-kappa B, inhibitory kappa B. But when IL-6 engages this receptor, the I-kappa B gets ubiquitinated or targeted for destruction. The I-kappa B goes to the proteasome, which is like a garbage disposal inside the myeloma cell. And the I-kappa B gets degraded and spit out of the myeloma cell, which leaves the NF-kappa B free to go to the genome inside the myeloma cell nucleus and turn on a lot of those bad things that we saw. More VEGF to create more blood vessels to feed the myeloma cells. ICAM in order to adhere tightly to those bone marrow stromal cells and turn on more IL-6 signaling. And all that IL-6 again increases survival, proliferation, and again, decrease myeloma cell death and increase treatment resistance. So what if we could put something in that garbage disposal? What if we can inhibit the proteasome? Then what would happen? Well, NF-kappa B then can't dissociate from I-kappa B, so we can't get to the nucleus to do anything. Nuclear factor kappa B just sits there, even though you have the IL-6. It's like putting a cork in the exhaust pipe of the myeloma cell. So all those factors that we talked about that causes the myeloma cell to live, proliferate, and survive, all of a sudden don't happen. So the myeloma cells start to die because they are starved of IL-6, starved of those adhesion proteins, which allow them to stick to the bone marrow stromal cell. And that's how the proteasome inhibitors work. But also, what do myeloma cells do? They produce lots of protein, those M proteins and those light chains. And stopping up the cork inside those myeloma cells causes those cells to pop open by inhibiting those proteasomes inside the myeloma cell. So Velcade was the first proteasome inhibitor that was approved by the FDA in 2003. And phase 2 trials in newly diagnosed myeloma have really reached it to be one of the keystone drugs that we use to treat newly diagnosed myeloma. Carfilzomib came out in 2012. It's an irreversible proteasome inhibitor without the side effect of peripheral neuropathy that Velcade had. Again, very high response rates for refractory myeloma, and now and sometimes we use it for upfront therapy for myeloma. And then the final proteasome inhibitor came out, Nenlara, which is an oral version of Velcade, which is again approved by the FDA in 2015. So that is one component, the proteasome inhibitors, which poison the myeloma cell, remove it from being able to adhere to the bone marrow stromal cells, and starve it of IL-6. So now Selinexor. How does Selinexor work? Well, inside, I showed you earlier that the myeloma cell has a lot of information going in and out of the cell nucleus, all those pathways that are being activated in myeloma. Well, how do things move in and out of the cell nucleus is important one. So EP01 is a protein that will pick up some of those tumor suppressor proteins that are hanging out in the cytoplasm of the cell. So, and it will escort it into the nucleus of the myeloma cell. It will then unload that tumor suppressor protein. And there are a number of different tumor suppressor proteins that will actually, as the brake to the myeloma cells, tumor suppressor proteins do exactly what they sound like. They suppress the tumor. However, myeloma cells have lots of exportin 1, which actually carries out those tumor suppressor proteins. And they carry out the tumor suppressor proteins more than they carry ones in. So you get this unbalance that there are more proteins, tumor suppressor proteins being taken out of the cell nucleus, allowing the myeloma to grow, and a very low number of tumor suppressor proteins inside the nucleus. And exportin 1 just keeps going in and out of the cell nucleus, escorting those tumor suppressor proteins out of the nucleus. And so exportin 1 allows tumor cells to escape death by limiting the amount of tumor suppressor proteins in the myeloma cell. Well, what if you can inhibit that protein that escorts the tumor suppressor proteins out of the nucleus? What if you could block exportin 1? Then what happens is that those tumor suppressor proteins begin to build up in the myeloma cell. And as those proteins that suppress the tumors begin to build up, it actually kills the myeloma cell from within, because I showed you how much proteins are running in and out of the nucleus. Now proteins are running in the nucleus but not out, which causes myeloma cell death. And Selinexor was the first in class of the exportin 1 inhibitors. And in preclinical in the laboratory, it activated a lot of those tumor suppressor proteins that kill myeloma cell. Remember, NF-kappa B, we talked about how important that is for myeloma cell survival. Inhibits NF-kappa B signaling, starves them of their important cytokines they need to grow and proliferate, and that's synergistically with other drugs. And you can see how you have the proteasome inhibitors inhibiting NF-kappa B. You have selinexor also inhibiting NF-kappa B and increasing the tumor suppressor proteins, which can be a very powerful combination to treat myeloma. So after the initial phase 1 studies came out, the STORM studies came out, where they were started treating patients with multi-drug refractory, penta-refractory. That means that they had several lines of therapy that failed with 5 different drugs at least. Try this new drug for myeloma, and they were given selinexor at 80 milligrams 2 days out of the week every month with dexamethasone. That was then, and I was happy to participate in that study. That was published and subsequently approved by the FDA a couple years ago for the treatment of myeloma. And these patients were on this trial. Lots of them had those high-risk cytogenetics. So these were folks that were pretty sick with myeloma, and they had lots of prior therapy, including daratumumab and Pomalyst and lenalidomide and Proteasome. So they had seen a lot of different drugs treated with this new medication. And it had a pretty good overall response rate as a single agent, but a 26% response rate and a clinical benefit rate, which means that you include the complete remissions, the complete responses, the very good partial responses, and those minor responses all together. And again, a very nice clinical benefit rate that patients could actually feel better. And especially with those patients that a lot of these patients have failed multiple different types of medications. When you look at how long it lasts, you have patients that were on this therapy for almost over 14 months, and many patients that were on therapy over 6 months. And you see that as the longer that the deeper responses are in deeper blue, but a lot of these partial responses happen within the first month. So this was a very effective therapy that worked very quickly. What were the side effect profiles? Well, patients, basically every patient had at least one or more than one side effect when treated with this. Primarily low blood counts, thrombocytopenia, low platelet counts, anemia, low red counts, and neutropenia, but also fatigue. And when we had patients on this trial, there was a lot of fatigue, quite a bit of nausea, and weight loss that occurred with this treatment. And so about half the patients required interruptions. And so when someone got really nauseated, really fatigued, or the blood counts were low, we'd interrupt it, or dose reductions at that twice weekly regimen that I had mentioned. We use a lot of supportive care, anti-nausea medications, and appetite stimulants to try and help folks along. But that was on the when we were giving it twice weekly. So then we moved on to the Boston trial. I love this. My kids didn't think this was funny, but I thought that I lost my khakis. When I lived in Boston, so I can say that you can say khakis and mean keys, not khakis. So the Boston study. The Boston study had patients that had, was a phase 3 trial. So it randomized patients between selinexor, and this time you'll see the selinexor was used just once weekly. So instead of twice weekly, just once a week they got selinexor. Just once a week they got Velcade. Again, we thought these drugs would work synergistically together. Or patients got very good therapy with Proteasome and Velcade alone. And they continued on this until the time of relapse, with the primary endpoint of the study being how long did it work, the progression-free survival. And again, patients had lots of high-risk cytogenetic patients and patients that had, again, multiple lines of therapy. Not as many as STORM, but Boston did have a fair number of patients that were on their second line or third lines of therapy with a lot of the current drugs that we use to treat myeloma. And you'll see, here's one of those Kaplan-Meier survival curves. You'll see the blue curve, which is the selinexor Velcade group, did better than the Velcade group, Velcade Dex group alone. So which then led to its being approved by the FDA. When you look at which groups did better, so the group to the blue group, or the group to the left, are basically all of those groups favored the addition of selinexor. There were no groups over to the right, which were just the Velcade Dex group. So especially if you were over the age of 65, that group really benefited from the addition of selinexor. The highest risk was the deleted at 17 P group did very well. And the patients that had not seen Velcade before or proteasome inhibitors before, of course, did well because both drugs were new to them. If you had previous lenalidomide therapy, it didn't really matter, which is a good thing because we use so much Velcade or Revlimid as upfront therapy. And again, we look at responses. Again, better responses than we saw with Storm. The combination worked better than the single drugs alone, with deeper response rates and basically all the risk groups as compared to Velcade Dex alone. Probably the important thing is that using that once weekly regimen, that there was less nausea and GI side effects and diarrhea than we had with a twice weekly regimen. The weight loss wasn't nearly as bad with the once weekly regimen as compared to the twice weekly regimen. And the blood counts were still a bit of a problem, where some patients did require medications to improve their platelet counts, and some patients required platelet transfusions because selinexor is a bit hard on the platelets, those other cells which do lots of cell signaling. And so the conclusions from the Boston trial was that in patients that had 1 to 3 prior lines of therapy, that the addition of selinexor with a just once weekly regimen was better than twice weekly Velcade and Dex alone. That the overall response rate and very good response rates were really good. Not a lot of peripheral neuropathy, that once weekly Velcade. And the good news that the median overall survival was not reached in the study arm. The treatment adverse events were manageable, and again, better with that once weekly regimen. Of course, this then led us to pursue, what about combining selinexor with that irreversible proteasome inhibitor, Kyprolis or Carfilzomib? Well, that, given the results of that first of the Boston trial, would this work even better? The one thing about the study that I was involved in with selinexor and Kyprolis is that it was still using that twice weekly selinexor. And even though that was a really good study, it was enjoyable to work with. We saw lots of good results and published a paper on it. When you compare the once weekly selinexor to the twice weekly selinexor, again, you see that once weekly selinexor had really significantly lower side effects compared to twice weekly. So even though I love the study I was involved in, really the moving forward dose for selinexor, I think a lot of people would admit, would be the once weekly dosing when it's combined with other therapies. And so the hematologic, the thrombocytopenia you'll see was less, the anemia was less than the twice weekly, the gastrointestinal side effects and the weight loss and fatigue was significantly lower with the once weekly regimen. That then led to the STOMP series of trials. And STOMP a series of trials looked at selinexor as a backbone treatment of different therapies for myeloma. So they combined selinexor with Velcade and Dex, Pomalyst and Dex, selinexor with Revlimid and Dex, with daratumumab and Dex. And the one in the red box was the selinexor with Carfilzomib or Kyprolis and Dex. And they did have one study that was for newly diagnosed patients. And so the SKD trial, the selinexor Kyprolis Dex, also looked at relapsed refractory patients, but that were not refractory Carfilzomib. So these patients had not seen Carfilzomib before. And the way that it worked was it used a dose escalation scheme. And so I'll show you that in just a second, how they increased the dose of the selinexor weekly, also increased the dose of the Carfilzomib weekly, because that was the moving forward dose for the Carfilzomib. And so when you look at the patient characteristics on this trial, you'll see that Again, lots of prior therapies that they had at least 4 prior therapies before enrolling in this trial. You'll see in the middle where it says prior therapies that basically a lot of those are the modern drugs that are approved by the FDA minus the drugs, the bispecific antibodies that haven't been approved yet. But there are patients that actually had CAR T that were on this trial. We'll talk about that near the end of the trial. Also, a lot of patients that had high risk disease. So 53% of patients on the Selinexor Carfilzomib Dex trial had high risk disease, including gains of chromosome 1q. So this is what I meant by the dose escalation trial, that there were different dose levels that were given. At dose 1, the Selinexor was given at 100 milligrams once weekly with 40 milligrams of Dex, and a lower dose of Carfilzomib once weekly. And 3 patients were enrolled in that study. And the dose limiting toxicity was that the patients ran into a bit of thrombocytopenia. The next dose was, well, what if we lower the Selinexor dose, but we leave the Carfilzomib dose alone? So in that group numbered 1-, 6 patients were put on that arm of the study, and there were no dose limiting toxicities. So maybe that was a sweet spot. Then the next group that was enrolled was Selinexor at 80 milligrams, with the Dex being the same, and as Carfilzomib now increased, and again ran into problems with low platelet counts. And there were other patients enrolled at other doses, but the moving forward dose, the best dose that had the least side effects in the way of especially thrombocytopenia, was at 80 milligrams weekly of Selinexor, 40 milligrams of Dex, and the 56 milligrams of Carfilzomib, again, on days 1, 3, and 15. So 3 out of the 4 weeks of the regimen. So how well did it work? When you look at overall response rate, is a 78% response rate. That is a fantastic response rate for relapsed refractory myeloma, including very good response rates for patients that had more than 3 prior lines of therapy and ones that had just 1 to 2 prior lines of therapy. The overall response rates for those high-risk patients still super good response rate. Look at the clinical benefit rate. Again, 81% clinical benefit rate. So those minor responses, partial responses, very good partial responses, complete responses, very good. Most of the responses that occurred with Selinexor Carfilzomib Dex was in that very good partial response, 90% reduction, or partial response, 50% reduction. And there were a smaller number of patients that had minimum responses, and some patients just had stable disease, which sometimes is not a bad thing. If your myeloma is getting worse and worse and worse, and all of a sudden it just arrests, that's not a terrible thing to happen. When you look at the depth of response, so this waterfall plot looks at, well, how deep were the responses? So each line is an individual patient. The ones that were in the gold color were patients that had 1 to 2 prior lines. Most patients have more than 3 prior lines of therapy. And you look at the patients that have failed 3 different drugs, the ones that are starred, and you see this is the best percent response. And some patients have very minor responses, but a lot of patients had deep responses that we had talked about. And the good thing is that this kicked in very quickly, that the responses were seen in the first cycle, and 23%, 23 patients had a response in the second one. So here's a swimmer's plot, and what you can gather a lot of information from this. So you look at how long some of these patients were treated. Some patients that had stable disease didn't stay on the therapy very long. Some of them, when they have the arrows, are still getting treated. So the arrows mean that they're still getting treatment, and where the blocks are, either treatment was discontinued or they progressed. And so few patients had the partial responses either stayed on therapy or progressed. The patient that had better responses and deeper responses went further out. And again, their patients as far as 26 months and 22 months that are still receiving drug or moved on to other treatments. Again, here are those survival curves, and they broke up the survival curves between 1 to 2 prior lines of therapy versus those patients that had more than 3 lines of therapy versus patients with high-risk cytogenetics and had triple class therapy. And the patients that had less therapy and that had less prior lines of therapy or triple class refractory tended to do a little bit better than the patients that had earlier lines of therapy, which is kind of the usual thing we see with myeloma. The more treatments you have, the harder it is to hang on to those responses. The median progression-free survival was 15 months. So median time on therapy for people relapse was over a year. And including 23, almost 2 years for some of the patients that were triple class refractory. The duration of response before they had to go on to the next treatment was about 22 months. The overall survival was not reached. So this was not a very good, a very tolerable regimen, because when you look at the thrombocytopenia, those little platelet counts, using that once weekly regimen for the Selinexor and 3 weeks on and 1 week off weekly for the Kyprolis, really did not have as many side effects as the study I was involved in. The thrombocytopenia occurred in about 33% of patients with grade 3, few grade 4, and any grade thrombocytopenia was about 77%. So you expect your platelet count to drop a little bit. And the side effects for the going forward dose, that I had mentioned earlier, not a lot of nausea. Any grade of nausea, about 77%, but not a lot of severe nausea associated with the regimen at that dosing. And fatigue was a bit better. The really bad fatigue was significantly better. So moving to that weekly regimen did retard a lot of those side effects that we had seen with higher, more frequent dosing of the Selinexor, not much peripheral neuropathy or other side effects. And so the conclusion of this trial, and the reason that it was kind of the moving forward dose, and the dosing that I use now when I use Selinexor combined with other drugs, is that the adverse events were all grades. So any kind of adverse event for thrombocytopenia was about 72%. So we see the platelet count drop. The ones we intervene on are about 50%. And I think that's pretty much what we see in real life, that we see that about half the patients we do need to intervene, usually with some of those platelet supporting shots. So the end plates that we use to have the bone marrow make more platelets is not an uncommon thing we combine with Selinexor. The nausea, the severe nausea, only 6%, very small. And we'll talk about in a second how we can eliminate that. And the anemia we worked on, and the fatigue, is still, plagues us, but, getting enough fluids in and being active really helps a lot of the fatigue associated with this regimen. But all of the side effects were expected and manageable supportive care regimens, and again, some dose modifications. The discontinuation, how many patients had to discontinue because of side effects, was only 15%. And at the moving forward dose that I had mentioned, the 80 weekly and the Carfilzomib at 56, 3 weeks on, 1 week off, was only 11% of patients had to discontinue because of side effects. So it was pretty well tolerated for a lot of patients. Again, the moving forward dose was the Selinexor 80 milligrams once weekly, the Carfilzomib at 56 milligrams, 3 weeks on, 1 week off, the Dexamethasone at 40 milligrams. And the overall response rate, again, 78%. So pretty good, very good response rate for these patients, including 44% for greater than very good partial response. And again, these lasted for about 15 months. What if you compare that to other myeloma regimens, including Kyprolis? And so The study that I was involved in, the Selinexor, Carfilzomib, Dex, the overall response rate was lower. It was 48%. The clinical benefit wasn't bad, and the very good partial responses weren't bad, but it was a bit more toxic. And we had to lower the Carfilzomib dose quite a bit more than the dose that was used in the STORM trial in order to accommodate some of the side effects. And so the dose that we had for the study I was involved in was Selinexor 60 milligrams twice weekly, Carfilzomib twice weekly, and Dexamethasone at 20 milligrams. For other relapsed refractory patients with a median of 2 prior therapies, the daratumumab carfilzomib dex, so DKD, frequently used therapy for relapsed myeloma, overall response rate is comparable to Kyprolis, Selinexor, and Dex. The PFS hasn't been reached in that study, so again, it's a good comparator between the two. And for relapsed refractory patients with 6 prior lines of therapy, the addition of Carfilzomib Pomalyst index, KPD, again, a very frequently used regimen to treat myeloma, the overall response rate is 50%. It's really hard to compare trials. So these trials were very different. Probably the one that you compare the best is probably the twice weekly Selinexor Kyprolis study. But those other studies, they're very different. Even though they contain Carfilzomib, they're pretty different studies. So it's always, you have to, when you do cross-trial comparisons, you got to be very careful in making those cross-trial comparisons, because they frequently can have different investigators in different areas of the country, different areas of the world. So they're a hard comparison. So my daughter thought this was funny, and I think it's true. So, you know, the moving forward dose for Selinexor, now how can we make that better? Well, we do have to keep an eye on the thrombocytopenia and neutropenia. And so it is not unusual for us to use those growth factors, especially the platelet derived, the growth factors that increase the platelet count to help support the platelet count. And I think that when we've given this regimen and other Selinexor containing regimens, the Nplate has been a really good drug in order to maintain adequate platelet counts. And I would say I haven't had my patients get platelet transfusion because we intervene with those platelet producing drugs pretty early. Selinexor can be highly immunogenic, which means they can cause quite a bit of nausea. When we have used olanzapine, which is a pill which does a fantastic job of controlling nausea, when we have that in the background on top of Zofran the day of treatment, we've had very little nausea. In fact, I just saw the patient that is on a Selinexor containing regimen right now. He's on olanzapine and Zofran and has had, no nausea since we started therapy with the once weekly regimen. You do have to keep an eye on the blood counts, including the low sodium levels. Thank goodness with the once weekly dose, and I haven't had to give anybody salt pills at all. And of course, we always have to watch for infection, including making sure that everyone has vaccines for the flu, and especially, of course, for COVID. The monitoring, we have to keep an eye on the blood counts. We usually have our patients come in because they're getting the Carfilzomib once weekly that we 3 weeks on, 1 week off, that we monitor for cytopenias and interact and engage the neutrophil count when it gets low, either with dose changes or growth factor support. We really have to watch the body weight, watch for dehydration. Hasn't been as frequent with the once weekly dosing, but it again, it works pretty well for tolerance. And we occasionally have to give patients hydration. With the Carfilzomib, you get hydration kind of anyway, so we kind of keep a watch on that. And we do start Selinexor at 80 milligrams or 100 milligrams once weekly, depending on the regimen that you would pick. And these are the different combinations that are used with Selinexor. So Selinexor Dex. Again, if you're gonna just use the two drugs, the FDA approved a dose, the Storm trial is using the Selinexor twice daily. But if you combine it with other drugs, you really got to think about using Selinexor on a weekly basis, because you can start to pile up side effects if you're using too much Selinexor. So the moving forward dose from the Boston trial, remember the Kakis, is using once weekly 100 milligrams of Selinexor, kind of standard dose Velcade, using Pomalyst and Selinexor. Again, that 60 milligrams, a bit of a lower dose of Selinexor, and kind of standard dose of Pomalyst, and daratumumab that I just started a patient on recently. We use that 100 milligrams of Selinexor. And in fact, on the last patient I treated, I started a little bit lower because the platelet count was a bit low, at 80 milligrams, and then kind of dosed up. And of course, from the Storm trial that I had just mentioned, with Carfilzomib, that 80 milligrams once weekly, and the Kyprolis at 56 milligrams. And so there was, I think, a couple interesting abstracts that were at a couple of the ASH and myeloma meetings that looked at the use of Selinexor after patients had failed CAR T. And this was from, I think, the from the Mount Sinai group that looked at 7 patients that had received a Selinexor containing regimen after they had received CAR T therapy and failed CAR T therapy. One patient was enrolled on the Storm study where they just received Selinexor and Dex. One patient in the Boston, and one patient in the Selinexor plus Carfilzomib study. And again, all patients responded, which I think is very encouraging, because we do need therapies that we can give after a patient has failed CAR T. 2 patients had progressed, and 1 patient withdrew consent, and 4 patients were still responding when this abstract was published a couple years ago. And so again, encouraging that we have therapies available to us when patients fail CAR T. So why is this important? Which I think is a really important question. Why the studies I showed you from a couple of years ago. So why is that important in 2020? Well, now we're using daratumumab and isatuximab as upfront therapy. So we're using it as first-line therapy, or first relapses, or an initial therapy with myeloma. So leaving the daratumumabs and isatuximabs for later lines of therapy really is kind of going out of fashion, in that we're using these anti-CD38 antibodies upfront for the treatment of myeloma. CAR T, so we need, when patients relapse, we need something that will work right away. We need something immediately available. And CAR T therapy is on back order. That the lentivirus used for CAR T has been a bit slow in getting patients CAR T. Even when that's available, it takes weeks to manufacture a CAR T for any particular patient. And patients can't wait that long. Sometimes patients can't wait weeks and weeks to receive CAR T. So we need a therapy that's rapidly effective to bridge patients until CAR T. And that's where I use the Selinexor regimens. I use a lot of these regimens, bridging patients to other potential therapies, knowing that I have about 6 months, maybe 8 months to work with, that these are very good therapies to bridge the next thing. The bispecific antibodies, when they get approved, which should be imminently by the FDA, will take some time to organize administration, because they'll likely be given in the hospital, so it'll take time to do that. So again, the Selinexor regimens are a good bridge until we'll be able to do those things. And one thing we know about some of the anti-BCMA therapies is that there's a cytokine release syndrome. And we know that the lower amounts of disease that patients come in with before they get some of these BCMA therapies like CAR T or bispecifics, the lower those side effects. So this is a good way to decrease the disease burden before you get some of these more definitive therapies. Not everyone in the country and in the world will have access to CAR T and bispecifics. So we need to have therapies available to them because they may not be in an area that will be able to do a CAR T or bispecific antibody. And of course, as I mentioned by that other abstract, that after these agents fail, we need some effective therapies. And the Selinexor was a really, is a good option to treat patients when they have failed these other treatments. So it ends up being another arrow in the arsenal against myeloma. And we just keep, thank goodness, we just keep finding, and the research continues to keep finding better drugs to treat myeloma, which has really been very encouraging to be a myeloma doctor and to have all these therapies, including 14 novel drugs that have come out, has been really encouraging and very satisfying. But we will get a cure, and then I'll be out of business. So thank you for your time and attention, and I will open it up to, and there's my email address if there are any questions.
Thank you so much, Dr. Cole. I really appreciate A, how fun you make your slideshows, and B, just your simple explanations of complicated topics. It's fun to hear from your point of view, why the trial went well, why it didn't go well, and walking us through it actually made it a lot more understandable. So thank you for that.
Oh, sure.
We do have time for a couple of questions if patients want to enter in questions. I'll start with a kind of different question. You're getting compliments, great presentation from patients, just so you know.
Thanks.
But one of my questions for you is, you've been a part of so many different clinical trials throughout your career. What's your favorite part about being a part of clinical trials?
That is such a good question. Because I'm at a very fortunate spot where I've been able to see a lot of changes. And a lot of patients, their comparator was the day that they got diagnosed. And my comparator is 15 years ago, when we were struggling to get any therapies. And if somebody were to go back to the 2005 me, when I had hair, and I wasn't so good at PowerPoint, and say, Craig, we have a drug that inhibits exportin 1 that has, for relapsed refractory disease, has a 70% response rate, or a bispecific or CAR T, I would have said that's insane. There's no way that someone with relapsed refractory myeloma that you'd get a 70%. You can't get a 70% response rate out of a blood pressure medication, no less from a cancer like myeloma. And here we are in 2022 with regimens that work as good, that are as effective at treating myeloma as, I don't even think my blood pressure medication works 80% of the time.
Yeah.
We have, and it's because of the science. And it is so encouraging for me to see the progress that has happened. And it's so exciting when I remember going into a patient's room, just elated that they had, still to this day, to say that they've had a very good partial response when that didn't even happen a few years ago.
Yeah.
I'll be honest, that when I first started doing this, never said the word, complete response. I didn't say that for at least 6 years, because you never had anything that worked that well. And now I can say, put a patient on a study, and a study in 2022, you better pull off a 50% response rate. That is if you can't pull off better than a 50-50 response rate, then you have to go stepping out, because it can't compete with the other clinical trials that are out there.
And how crazy, right? Because just 2 years ago, we're talking about 20% overall rate. Everyone was like, whoa, we made it to 20.
It is,
Yeah.
I'll tell you the super quick story. When I was working in the lab at Dana-Farber, and I got on the elevator with Dr. Anderson, and he told me, I had been up it seemed like all night doing an experiment, and he said, that the Revlimid studies were showing, 80 to 90% response rates. And I knew when I got on the elevator, the response rate was 30%. And I got off the elevator and I'm being told the response rates are 80 to 90%. It just energized me to know that those response rates mean that people are surviving this disease.
Yeah.
That people, every little response rate is someone that has responded and is doing well. And that is just so exciting. Still, we have a little abstract that we're working on for ASH, and I'm just thrilled to get out that information because I know that it helps people.
Yeah. Yeah. Okay, a couple questions here. One of them, they're giving their myeloma background, but essentially they're asking for a second opinion. Are you available for second opinions via telehealth?
Yes.
Okay. And how would they go about contacting you for that second opinion?
So the HealthTree, I think you guys have all my contact information.
Yeah.
And so actually the telehealth second opinions I've gotten have been through HealthTree, but also my email address, Cole, CRAI at MSU. I can set it up also.
Okay, awesome.
And I think I saw another.
Yes. So one of the questions here, he's asking if you can compare. I'm going to change the question just a little bit. Are daratumumab and selinexor comparable? Why or why not?
Wow. So I could go on for days.
I know.
So this is the way I think about it, especially with selinexor. Selinexor is a true biologic. That the daratumumab has a little biology. So when the daratumumab antibody sticks to the myeloma cell, it does inhibit some of the signaling in the myeloma cell, which causes it to die. It does a little bit of that. What it does a lot of is it activates the immune system to descend upon the myeloma cell. So the daratumumab works a little bit at poisoning the inside, but does a lot of getting the outside, the microenvironment of the myeloma cell to descend upon it to kill it. Selinexor is a biologic. So if I showed you a myeloma cell and gave it selinexor, on the outside, it would appear that nothing had changed. On the inside, all sorts of stuff is changing. There's a one thing about myeloma cells, they do all that signaling inside of it. They do all this signaling. And you can use that, you can leverage all that signaling to the advantage of treating the myeloma. So it poisons the inside of the myeloma cell more than the other cells in the body, because myeloma cells are signaling like crazy. So the outside, the immune system really isn't paying attention to the myeloma cell and selinexor, but inside the cell, its biology is being turned upside down. While daratumumab, it's the outside in.
That's a great, concise explanation. And it just makes me realize we need to have more sessions on therapy. Getting to know your myeloma therapy, I think, is such an important series so that people understand what's going on.
Yeah.
One more question. Are any of the trials being done with lower doses of Dex? This could be asked about any clinical trial.
Absolutely.
Involves Dex.
In fact, at the last international myeloma workshop meeting, that the point was brought up about the idea of maximum tolerated doses, and how one thing that we learned during COVID and over the years is how much Dex to get away with. That it's not the maximum tolerated dose, but what is the maximum effective dose?
Yeah.
Especially when you're combining with other drugs. So if you're using Dex all by itself, you got to use high doses of Dex. So you got to overcome all those obstacles those myeloma cells are putting up. But it makes sense that if you're using dexamethasone with other drugs, you could probably lower the dexamethasone dose. So a lot of clinical trials are now being written with lower doses of dexamethasone, especially for the groups of people that have problems with dexamethasone, including people that are older, they're over age 65 or 75, where almost automatically we're using lower doses of dexamethasone. Our goal absolutely is to eliminate dexamethasone in myeloma therapy. So we have eliminated a lot of the old-fashioned chemotherapy. We've gotten rid of melphalan pills. We've gotten rid of busulfan pills. I can't even believe I even said that. Now we got to get rid of the Dex. And I think attacking the biology and attacking the outside of the cell will allow us to get there.
Yeah, because I was going to say, it doesn't mean that Dex is ineffective. It just means there's a more effective way than Dex. Is that true?
Yes,
Okay.
yes. And the challenge, the gauntlet to really throw down is not use the highest tolerated dose. How much can you take? The question is, because people can take a lot of Dex, the question is, what's the most effective dose of the Dex?
Yeah.
And not because it doesn't necessarily have to be the highest tolerated dose.
Yeah. Well, thank you so much, Dr. Cole, for your shared time and knowledge. This was a great session, and I really appreciate your preparation and work.
Thank you.
We're going to finish with just a couple of outro announcements for the audience. So tonight, there's our Northeast Myeloma Community Chapter. If you live anywhere from Maine to Pennsylvania, please come join us. We're going to be meeting with the registered dietitian about nutrition advice. And then on the 13th, we have 3 different events. 2 of them are shown here. We have our Nutrition and Wellness for Myeloma chapter talking about combating anemia, fatigue, and GI side effects. And then our Relapsed Refractory chapter talking about Pomalyst or pomalidomide. So please join us for any of those events and even more events that I didn't mention. Link is found at the bottom of this slide and will be sent in that follow-up email. And a big thank you to our sponsors, Bristol Myers Squibb, GSK, Genentech, Janssen Oncology, and AbbVie. And a big thank you to each of you for helping us build this community, for your questions and participation. I appreciate you all. Hope you have a great rest of your day. Thanks, everyone.
Yeah, thank you.